So it's a little bit of a smaller forum today because a lot of people couldn't make it at 4 o'clock, which is an unusual hour for us. And I really appreciate Dr. Davila making an effort to come and give us this talk. As you can tell, he's a professor of medicine, anesthesiology, and radiology. Received his MD from the University of Puerto Rico. And then had a short interlude in Houston,
in San Antonio.
San Antonio.
The Army.
The Army, yeah.
Yeah.
Maybe it wasn't so short. Then he came to Washington University.
Yeah, 86.
So he'll tell us about the phenotype-genotype relationships in hypertension or
Thank you very much.
We're happy to have you.
Thank you. Appreciate it. Okay, well, I am a cardiologist, so we're going to start with a clinical case. So this is a woman that I took care of about 4 years ago in medicine in the cardiology ward. 65-year-old woman presented to the emergency room with dyspnea and exertion, so when she tried to do some activity, she would get short of breath, fatigue. She's had hypertension for 20 years, which had been treated on and off with water pills, but she wasn't really that compliant with her medicine. So on exam, she had a heart rate of 95, regular, significant hypertension compared to 180 over 100. And the lungs had this crackly sound all the way up, third of the way up, which implies that you have water inside your lungs. This was the X-ray, and somebody other than Chandler maybe can tell me what they see there. So there's a lot of water where there should be black. So all the white stuff here, that's all what we call pulmonary edema, which is a very classic presentation for heart failure. So she had a typical heart failure presentation. And most people will think then, well, heart failure, she has a bad ventricle, meaning that the ventricle, the pump, doesn't work. The systolic function is down. So I'm going to show you the echo. And so the echo is on the left panel, and this is the filling pattern of the ventricle. And so that doesn't look like a ventricle that doesn't contract well, right, Chandler? Pretty good. Yeah, so the contractility, this is an echo, this is the right ventricle here, this is the left ventricle. The contractility is quite normal. And so the problem with this ventricle is that the walls are markedly thickened. So this is the septum, the posterior wall, and normally the walls of the ventricle are about 1 centimeter. And this is almost 2 centimeters throughout. It's a very hypertrophied ventricle and an abnormal filling pattern, which shows a decreased early filling wave, an increased atrial contraction wave, and increased deceleration time. And this is what we call stage 1 of diastolic dysfunction, or impaired relaxation. Okay, so clinically, then the echo findings, she had normal LV systolic function, left ventricular hypertrophy, markedly thickened walls of the ventricle. She also had diastolic dysfunction. These are echo findings. Clinical diagnosis, hypertension, and diastolic heart failure. So these are the traits that we have been interested in studying for a long time. And these are traits or phenotypes that characterize what we define as hypertensive heart disease, which really means the effects of hypertension or high blood pressure in the heart. Okay, so I'll talk a little bit about the epidemiology of hypertension and hypertensive heart disease. It should not be a surprise to many of you who study cardiovascular diseases that cardiovascular disease is the #1 killer of Americans, more than any other disease, including cancer and stroke, cancer and other pulmonary Alzheimer's disease. And so of all the people that die, again, cardiovascular disease is the #1 cause. So if you look at The prevalence in 2006 of cardiovascular disease in the U.S., about 80 million people have this problem, and of those, about 73 million have hypertension, which is, again, high blood pressure. If you look at the causes of death, high blood pressure here looks like it's only 6%, but these are people that die with hypertension and nothing else. But what actually happens is that most of the deaths attributed to heart failure, stroke, and coronary heart disease, hypertension is, if not the leading cause of the problem, it's one of the major contributors to these other problems. You may think that high blood pressure is a disease of the elderly. So more than half of the people 50 and older do have hypertension. However, it's not a trivial problem in younger people, and in fact, there's a lot of data to suggest that high blood pressure starts in our 20s, 30s, but it kind of goes up and down, and it's not until we get to our 40s and 50s that it stays up on a regular basis, and that's when the diagnosis is made. But really, the disease starts very early. So again, hypertension, very common problem in the U.S., 73 million Americans. It's a very common cause of, again, what we call hypertensive heart disease, ventricular hypertrophy, diastolic dysfunction, which occurs in 25 to 50% of those who have hypertension. And the end results of one or both of these is what we call the syndrome of heart failure, which comes in two flavors, systolic and or diastolic. About 5.5 million Americans are living right now with heart failure, and about 500,000 every year develop heart failure. So, if you have hypertrophy, for example, there's increased morbidity and mortality as compared to hypertension alone. A 50% increase in cardiovascular events, 4 to 6 times increased mortality. Diastolic dysfunction is also not an irrelevant trait. If you have it, hazard rates of greater than 8 for all-cause mortality. And there is a lot of evidence to suggest that there are molecular and genetic mechanisms, myocardial metabolism, that could be the cause of this hypertensive heart disease. Another slide to show that the incidence of heart failure, if you have LVH designed by EKG criteria, LVH is the most common risk factors for development of heart failure, whether you're young or old, women or men. It's a very important risk factor. Now, hypertrophy comes in two flavors, and I'm going to expand more on the hypertrophic phenotype because that's the one that we have most data, but similar studies can be made for diastolic dysfunction and other of these phenotypes that I have described. So, hypertrophy comes in two flavors. One is a pathologic or bad hypertrophy. The other one is a physiologic or good hypertrophy. Pathologic hypertrophy, we know that it's associated with increased ventricular ectopy and arrhythmias, and there's a lot of epidemiologic data to show that. Decreased coronary reserve, meaning that the ability of the coronaries to vasodilate in response to a stress is decreased. So decreased perfusion to the heart muscle. As we saw in the case, there's an impairment of diastolic filling, and there's a lot of fibrosis in the myocardium, in the interstitium, and that is all absent in physiologic LVH, which usually we associate with exercise. The severity of the hypertrophy is also important. And this data from 1990 show that the more the left ventricular mass is, the higher the 4-year incidence of cardiovascular events. So not just the presence or absence of hypertrophy, but also the severity is associated or related with cardiovascular events. So let me switch gears here a little bit and talk about a little bit of myocardial metabolism in hypertensive heart disease and try to put it all together. So we know that the normal fasting adult heart uses fatty acids preferentially over glucose for energy production, for production of ATP. So if you look at this cartoon here, this is a myocyte, this is the plasma membrane, the cytosol, and the mitochondrial matrix. You have all these enzymes that are transcribed in a coordinated fashion by this enzyme here, this gene called PPAR-alpha. And it's a critical transcriptional regulator of cardiac, lipid, and energy metabolism. So it controls of these enzymes involved in fatty acid transport, in bringing fatty acids into the myocytes, peroxisomal fatty acid oxidation, and also mitochondrial fatty acid oxidation, which is where most of the ATP is produced. And this, by the way, is based on many of the studies by Dan Kelly when he used to be at Washington University. So this peroxisome proliferator activator receptor alpha, or PPAR-alpha, is a transcriptional regulator. It heterodimerizes with this other compound, retinoid X receptor, and some PPAR response elements, and in the presence of 3G1 alpha, and it's a ligand-activated transcriptional factor, so the ligands are fatty acids. So when there's a lot of fatty acid in the cell, it activates this complex, and this complex activated, then it's in charge of the transcription of this fatty acid transport and oxidation enzymes. So the machinery to burn down fats and produce ATP is activated. It's ramped up. So we also know that in the normal fetal heart, glucose is the preferential substrate for energy production. There are many reasons for that that we're not going to go into, but just take it by face for now that glucose is the primary substrate for energy production in the fetal heart. Very quickly after birth, animals and mammals start using fatty acids as the primary source of fuel. And we know that in humans who have genetic defects in some of these fatty acid oxidation enzymes, when posed to conditions of starvation, like for example when they get a viral syndrome, in a situation where they cannot get glucose, these humans develop hypertrophy of the ventricle because they cannot use fatty acids, and that's also been associated with development of heart failure and sudden cardiac death. So from that data, we know that then humans with genetic mutations of myocardial fatty acid metabolism develop hypertrophy, heart failure, and/or sudden cardiac death. Now take the situation in a pressure overload ventricle secondary to hypertension, and what happens to energy metabolism? Is it preferentially fatty acids or glucose? And what happens in the heart failure animal? Is it fatty acids or glucose? We're going to look at some of the data on that. So this is an experiment that on animals with hypertrophy created by aortic banding. And under control conditions, the control animals and the banded animals at rest use the same amount of glucose and the same amount of fatty acids. When presented with a situation of stress, such as giving dobutamine, which increases the heart rate and the contractility, the glucose metabolism increased, fatty acid metabolism decreased, and this was associated with contractile dysfunction. So now we start seeing a connection between utilization of substrates and contractile function. These animals, by the way, had normal function at baseline. We also know in other animal models, these hind mice, that in heart failure, they have downregulation of these enzymes that are enzymes of fatty acid metabolism when they develop hypertrophy and heart failure. This is a control enzyme. This is ANF, another positive control showing that in hypertrophy and heart failure, atrionatriuretic peptide is upregulated. Okay, and this is again work by Dan Kelly at Washington University showing that in hypertrophy and heart failure, there's decreased myocardial fatty acid beta oxidation enzymes. And they say that in their paper that the switch in substrate utilization in hypertrophy and heart failure is a recapitulation of the fetal energy metabolic gene regulatory program. So reversion to the fetal energy gene program. So now we have one more piece of evidence showing that animal models of pressure overload develop hypertrophy, heart failure, and that's associated with decrease in the fatty acid metabolism gene expression. So this is where we come in. We started about 10, 15 years ago starting to look at this problem, and we have an interest in doing phenotyping characterization in humans, so trying to apply these animal concepts and see if they happen also in humans. So first of all, let me tell you a little bit about some of the work with echocardiography by other groups. We know that in the process of development of hypertensive heart disease, the normal heart goes into a remodeling called concentric remodeling, where the walls of the ventricle become thicker, but they're not quite, they don't meet the criteria of hypertrophy. Over time, then this other condition develops, which is called concentric hypertrophy, where the walls of the ventricle become thicker and impinge on the cavity of the ventricle, just like the example that I showed you. And finally, over time, when the concentric hypertrophic response can no longer be sustained, the ventricle starts to dilate, and they develop this condition called eccentric hypertrophy, and this is where patients develop systolic dysfunction. At this stage here, there's diastolic dysfunction, later on systolic dysfunction, which is always accompanied by diastolic dysfunction. So this is one of the early studies that we did. We looked at patients with hypertension and LVH and compared them with those who had hypertension and no LVH. And we use this index here, which is sort of a non-invasive poor man's way of looking at contractile function. And we give these people dobutamine, and clearly those who had hypertension without LVH, the contractile function improved in a linear fashion compared to the ones that had hypertension LVH. They did improve somewhat contractile function, but clearly not as much. And that was significantly different at all stages. Both groups had normal resting LV function. So here we see a human equivalent of the animal studies that I showed you earlier, showing that there is decreased contractile reserve. And we know from animal studies that decreased contractile reserve is a predictor of the subsequent development of systolic dysfunction and heart failure. With the help of one of our collaborators, Rob Rockler, also from WashU, we have been looking at humans at myocardial fatty acid metabolism by use of C11 palmitate with PET, positron emission tomography, C11 acetate looking at myocardial oxygen consumption, C11 glucose looking at glucose metabolism, and more recently C11 lactate to look at lactate metabolism. So I'm going to show you some of the experiments that we have done in the past few years. So we bring patients in. These are very extensive protocols, usually last 5 or 6 hours. We do look first at myocardial blood flow with PET, myocardial oxygen consumption, myocardial glucose uptake. We do an echo, then wait some time for the tracer to decay, and look at myocardial fatty acid uptake and oxidation with C11 palmitate, and then finally do an MRI study looking at contractile function with the use of strain. With this method, we looked at people who had systolic heart failure and showed, as in the animal models, that compared to the normal controls, people with heart failure had lower fatty acid utilization, lower fatty acid oxidation, and an increase in myocardial glucose utilization. And again, this is a model, human model of a dilated but also cardiomyopathy, but secondary to hypertension, and they also have increased LV mass compared to the normal controls. In a subsequent study, Lisa de los Fuentes, one fellow working in my lab, looked at a larger number of patients here, in this case, patients with hypertension, LVH, and normal LV function, another group of dilated cardiomyopathy with hypertrophy, and healthy controls. And she showed in multivariate analysis that fatty acid oxidation was the second most important independent predictor of left ventricular mass or hypertrophy. In a subsequent study, Lisa looked again at this relationship in a number of patients with also hypertension, hypertrophy, and some of them with heart failure, and showed that there's an inverse correlation between LV mass and fatty acid oxidation. And in a subgroup of these people showed that they had those with hypertension and LVH and normal systolic function. They had lower myocardial strain, it's an index of contractile function, lower myocardial efficiency, and a trend towards decreased myocardial work. So these are kind of the human equivalents of some of the animal studies that have shown similar findings. So we now believe that humans with LVH and heart failure had decreased myocardial fatty acid metabolism and increased myocardial glucose metabolism. So now the garden variety of pressure overload secondary to hypertension seems to suggest that the development of hypertrophy and heart failure is associated with decreased fatty acid metabolism and increased glucose metabolism. So at this time, we're thinking that there seems to be a connection between metabolism, contractile function, and gene expression. And this is where we start looking at potential contribution of genetics in the development of hypertensive heart disease. So there's more evidence of the potential contribution of genetic influences in hypertrophy. For example, we know from studies in hypertrophic cardiomyopathy, which is a disease that happens in humans in which one gene is associated with this disease called hypertrophic cardiomyopathy. So it's usually a mutation in one gene. We know that this runs in families, and most of these families have severe hypertrophy, and there's association with increased risk of development of heart failure and, more importantly, sudden cardiac death. But we also show from these family studies that this single gene variant exhibit what we call variable penetrance. So in the same family, you can see some people who have the most severe phenotypes, severe hypertrophy, sudden cardiac death, heart failure, and others who also have the mutation have less severe forms of the disease. Not so much hypertrophy, they don't have any arrhythmia, they don't have sudden cardiac death, and so forth. So this suggests that, yeah, this one gene, one disease is a good idea, but probably there's other gene-gene interactions or gene-environment interactions that may be modulating that variable penetrance in these families. Now, the hypertrophy and the hypertensive heart disease that we're studying is not the one gene, one disease. We're looking at it as a complex disease in which many genes influence this disease spectrum. We know from epidemiologic study that LVH and many of these other traits or phenotypes, they do tend to run in families. We also know that they can precede, so hypertrophy can precede or occur in the absence of hypertension. We also know that it's more common in certain racial groups. And we also know that there's a significant heritable component to it, with heritability about 50%, to explain that the variance in hypertrophy. So these are compelling pieces of information that tell us, or at least suggest that at least some of it is influenced by genes. We also know that there are many other studies showing that this PPAR-alpha complex, and the PPAR-alpha complex I'm using sort of loosely to represent PPAR-alpha, gamma, PPAR-delta, CD36, and many other of these genes that are involved in myocardial metabolism. We know from data in humans and animals that, for example, PPAR-alpha is expressed in myocytes and other highly metabolic organs. There's a lot of data to suggest that there's a significant role in diabetes, obesity, dyslipidemia, inflammation, and atherosclerosis. PPAR-gamma, for example, is expressed in adipocytes, macrophages, and endothelium, which are major players in cardiovascular disease. PPAR-delta is ubiquitously expressed, and I'm not going to talk too much about CD36 because there's an expert in the audience that knows a lot more than I know about CD36, so in the interest of not making a fool of myself, I won't say too much, but I think Nada would agree that CD36 is expressed in myocytes, adipocytes, monocytes, and red cells. In the heart, it facilitates the entry of long-chain fatty acids, being associated with diabetes, CAD, hypertension, and even malaria susceptibility. And some mutations of CD36 have been associated with cardiomyopathy. So, at this time, we decided to get involved in some of these phenotype-genotype studies. And the hypothesis of our study is that genetic variation of this PPAR-alpha complex and CD36 genes modulate the hypertrophic phenotype in humans through its effects on myocardial metabolism. Initially, we started with a candidate gene approach, and so we postulated that some of these genes would interact with these traits, hypertrophy, diastolic dysfunction, heart failure, etc. Through single SNP associations. Then we moved on to SNP association in the same gene, and then subsequently to gene-gene interactions. More recently, we have been funded to do a GWAS study, which is a genome-wide association study. And in this, we have proposed to look at interactions with these different traits in individual genes, gene-gene interaction, gene environment, and also looking at genetic pathways. So let me tell you just briefly to touch on this genotype-phenotype studies. So comes in basically in two varieties. The linkage studies are the traditional studies looking at genetic association. The problem with linkage studies is that it requires a family structure, what is also called a pedigree. So you need either SIP pairs, or ideally you need 2 or ideally 3 generations, so grandparents, parents, and children. These are very hard to do. They require a lot of resources. So we have not opted for that option, but in fact we have opted for the option of doing a genetic association study, which is these are by definition population-based. And the idea is to track the coincidence of genetic variants and disease traits or phenotypes in large, unrelated populations. The only problem with genetic association studies, or one of the major problems, is that they are subject to what is called population stratification or admixture. And that means that heterogeneous populations, different racial groups, have to be analyzed separately. That has to do with the fact that if you don't do that, you can get false genetic association with the disease, when both occur with increased frequency in a subpopulation of a mixed cohort. This has to do with the allelic frequencies of the different populations. And I will explain that in one subsequent slide. So we initially started with candidate gene studies. The issue here is that you need an a priori hypothesis-driven candidate gene, and based on the information that I have given you, our candidate genes are genes involved in myocardial metabolism. The second study that we're doing now is a genome-wide association study. The nice thing about this is that we don't require an a priori candidate gene. It's considered by many to be a big-time fishing expedition, and that's why the NIH is not funding too many of these nowadays. We have been collecting data on humans for about 8 or 10 years now. We have about a database of about 1,500 people, and growing every month. We phenotype about 30 additional subjects. We get an extensive evaluation on this patient. We do cardiovascular history and physical exam, get blood for all the usual things, lipids, glucose, insulin, have blood saved for additional biomarker assays. We also obviously extract DNA for genetic analysis. Everybody gets an echo, everybody gets a carotid ultrasound. Most people get ambulatory blood pressure monitoring, and I left out here that also a fair number of people also get Holter monitoring, 24-hour Holter monitoring. We look at arterial compliance. Some of them get stress testing, PET imaging, and MDCT in about 15–20% of the subjects. So they're extensively phenotyped, and so this is where we're deriving most of our data. So let me just give you an example here of one of these studies. So PPAR-alpha, an Intron 7 variant, has been associated with LVH. This is not data from our group, it's from another group. But just to show this G to C polymorphism in the Intron 7 PPAR-alpha gene, cytosine Intron 7 frequency is about 17% in white. I'll show you some data that the frequency of that is higher in black. And so these are patients who have this Intron 7 polymorphism, and those that are homozygous for the cytosine allele exhibit significantly higher LV mass compared to the other group. So these are patients with hypertension, so pathologic LVH, men, particularly men, associated with that Intron 7 polymorphism. This is an interesting part of it because these are, what they did here for the second part of the study is that they got young army recruits of the British Army. These were people in their early 20s, and they did echoes, actually MRIs before and after subjecting them to exercise. So some of them developed physiologic hypertrophy, and they again associated that CC as a predictor of higher hypertrophic response compared to the other groups. We looked at this Intron 7 polymorphism early on in our patients and compared the African Americans, 83 versus the non-African Americans. These are the demographics of them. And we clearly showed that for the African American, the C allele frequency is significantly higher, 59% versus 18% in non-African Americans. Again, what this is showing is the issue of what I mentioned before, population stratification. If you analyze the two racial groups together, you're going to get a frequency that is somewhere in between, and you may find false associations with the disease. So that's why the racial groups have to be separate. When we look at this again in that same group, we found significant association with systemic metabolic indices such as triglycerides, body mass index, HDL cholesterol, glucose, and insulin. And also, some of the metabolic indices were found to be significantly associated with LV mass, triglycerides, body mass index, HDL cholesterol, glucose, and insulin. So, one potential mechanism by which this is all playing out, this Intron 7 polymorphism may have direct effect, modulating effect on myocardial PPAR alpha expression modulating the hypertrophic phenotype and maybe some of the other phenotypes. But also what is also equally plausible or even more possible is that intron 7 is exerting effects on systemic expression of PPAR alpha because it's associated again with higher BMI, lower cholesterol, higher triglycerides, higher glucose and insulin, and in an indirect way it's modulating that hypertrophic phenotype. This is one of the things that we're still investigating with this and others. One of the issues that we have encountered in dealing with these traits or phenotypes is that they're very complex and they tend to interact among themselves. So, for example, we know that people that are obese, for example, have higher LV mass. They also have higher frequency of hypertension. They also have more dyslipidemia. So, is the response of the LV mass secondary to them being obese? Is it due to their lipid abnormalities? Is it due to their hypertension? It's hard to tease out those things. So one of our colleagues, Charles Gu, came up with this method, application of method that is known in other fields. It's the use of independent component analysis to extract these latent hypertensive heart disease phenotypes or traits. And let me just give you an example. So what it does is that by doing the independent component analysis in this group, in this case, let's talk about the Caucasian population. So C here stands for Caucasian. We can then look at a high risk and a low risk group. So in terms of age, for example, it's very comparable, the two, but you can see that the lower risk group has a lower BMI, so they're less obese. Their blood pressure seems to be lower. And we selected this equal to have the same ventricular function, so that's why they are the same. But they had more normal diastolic function than the high-risk group. A measurement of vascular hypertrophy is lower, and their LV mass was also lower. So, when we looked at the independent traits and looked at the genetic association, the independent traits showed absolutely no genetic association. But for example, in the case of this intron 7, when we look at this by using the independent component analysis, whether you use a 2 or a 3 or a 6 way independent component analysis, we found significant association with that intron 7 and several others. So this is a new way, so to speak, of looking at the hidden data that is on this phenotype, multiple phenotypes that are interacting with each other. In more recent work, Lisa de la Fuente, who now is a faculty member in my group, she looked at gene-by-gene interactions in this phenotype using a Bayesian network analysis of several genes, CD36, PGC1 alpha, and PPARs. In this example, in the African American cohort, and this BNT analysis showed significant gene-gene and cross-gene interactions for the phenotype of left ventricular mass and body mass index. And these interactions suggest that there is epistasis, which is the effect of one gene modified by one or several other genes. May be a mechanistically important process in the metabolic modulation of hypertensive heart disease-related traits. So this is a paper that was published recently in JAMA, looking at genetic variants associated with cardiac structure and function in people of European descent, so in Caucasians. Just to show you how complex these studies are. So this is a GWAS study. In the stage 1 of this study, they look at data from the ECOGEN consortium comprised of 12,600 European ancestry patients. And they found an association between some of these echo variants and 2.5 million sleeps. Okay, so how do you kind of funnel this into a more reasonable database to see which ones are the important things. So then they look at these SNPs in a second cohort now composed of 4,000 people, again, of European ancestry. And because of all the multiple testing that is involved, they have a very rigid pre-specified P level of 5 times 10 to the minus 7 to imply genome-wide significance. This is what's called a Manhattan plot, showing some of the associations in the different echophenotypes, and I'm going to focus on here on left ventricular mass. So they found 3 genes that cross that threshold of 5 times 10 to the minus 7. So now the work is to see how the hell these genes may influence the hypertrophic phenotype. So now we have to go back to the basic science lab and try to figure out how this plays out. So this is a very complex type of study. We are looking beyond the GWAS data, and we're trying to look at what we call pathways. So, and this is a study by one of the postdoc students working with Charles Gu and our group. And what he did here is he applied this pathway-based genome wide association study, applying it to the Framingham Heart Study, which, by the way, the whole data set, including genes and echo data and all that, is available freely on the internet, on the NHLBI website. You have to apply for it, but anybody can obtain. So we looked at this, or he looked at this, and again in pathway-based. And here's an example of what he found. So what is listed here is 2 pathways that were found to show significance with the phenotype of interest. And if you look at, for example, the individual SNPs, if you look at them individually, for example, this one would have ranked 271,456. So there's no way that this would have ever come out of any individual single SNP analysis. But now, when you look at them in a pathway base, so the entire pathway comes out as being significant. So I think that this is potentially one of the ways that we can get a little more information out of this genome-wide association study, and this is actually what we had proposed to do on our ongoing R1, and it's hopefully the way to go. So talk a little bit about the issues, and so we have to establish disease heritability in this genetic study, identify genetic regions and genes, and that's what we're doing now. And then after this is all done, have to go back to the basic science lab and collaborate with the basic scientists to really evaluate the functional relevance of these genes in the disease. So going back to our clinical case, this woman who I saw 4 years ago, I know that she has been readmitted to the hospital 7 times in the last 4 years. She had a stroke, she's in renal failure, and she lives in a nursing home. So this disease is associated with a lot of cardiovascular morbidity, and she's very frail, and I am sure that she will not be with us much longer. So this is a very, very important medical problem, and a lot of studies need to be done to try to elucidate them. I want to thank my collaborators, Lisa de la Fuentes from my group, Rob Roppler from Cardiovascular Imaging Lab, Charles Gu and DC Rao from the Genetic Epidemiology Program, and obviously funding from the NIH. With that, I'll stop here, and I will be glad to answer any questions.
Questions?
Everybody's totally confused.
I have a
Yes.
question. The PPAR-alpha polymorphism that you talked about, it's
The-
not known what it does to PPAR-alpha?
Intron 7?
Yeah.
Not exactly, no. So the possibility is obviously that it's an intronic SNP, so the likelihood of causing a change in the proteins it's lower, but it may be in what we call linkage disequilibrium with some other.
But nobody has looked really at PPAR-alpha targets or at...
Not that I know of. Yes.
I have 3 questions. One, do you see from this information any clinical implications yet? Can you think about any clinical
Well, the clinical
procedures or
right. So I think one of the ideas is once you identify which genes are implied in the disease process, then obviously the next step is to how you can manipulate them pharmacologically, for example, with drugs that target the transcription or target somehow the genes, so you can manipulate them in some ways like that. So that's a field of pharmacogenomics. But you need to know which are your targets first before you can manipulate.
And my second one is when an individual actually develops a functional hypertrophy and he has the genetic background, do you see how it can be, is there any contraindication? Is it a kind of a conflict in the development of the disease? Because on one hand he has a good hypertrophy and like that.
So from what I know, and Chandler may be able to help here a little bit, from what I know, people who develop the physiologic hypertrophy, there are no untoward bad side effects from that type of hypertrophy. We also know that, for example, elite athletes who develop this physiologic hypertrophy within 8 to 12 weeks of stopping their exercise, they almost go back to normal. So it regresses very quickly. Chandler, you want to add something?
The question I was going to ask is, in pathologic hypertrophy, if we treat people aggressively with antihypertensives, does their LV mass shrink? Do they also get regression of hypertrophy?
That is a very good question, and I actually had a slide and I took it out in the interest of time. But we do know that there are drugs that regress the hypertrophy. So 2 points that I want to make. So the ACE inhibitors, the type of drugs that affect the angiotensin, renin-angiotensin, aldosterone system, they do the better job at regressing hypertrophy, but they don't normalize it. So you develop hypertrophy, you treat it, you get back to some level, but that level is never normal. Okay, and the other medications do it also to a much lesser extent. So even after controlling the blood pressure, the hypertrophy never goes back to normal. That is a great question. Yes.
Going back to the PPAR-alpha.
Yes.
Stuck on that.
You're drilling me on PPAR-alpha. Good.
The frequency is very different in the African Americans and the Caucasians.
Yes.
But is the effect the same on the LVH? I mean, I think you went through it quickly, and
I actually, so the hypertrophy data so we do know that African Americans have, for the same amount of hypertension, they have more hypertrophy. If you compare with the hypertension in Caucasians, for the same amount of hypertension, they mount a more aggressive hypertrophic response. We haven't pieced out the differences between the different PPAR-alpha SNPs. We're in the process of doing that. That's part of the work that Lisa is doing.
Okay, so it hasn't been looked at.
It's being looked at as we speak, but we
Because
don't
if it
have
has the same effect, I would think it's not, well, I guess it still could be in linkage with something else. But
Absolutely.
if it has the same
Yes.
effect, it's probably the culprit, right?
Well, that's one of the possibilities. Any other questions?
Any other questions? No, thank you so much.
Thank you very much.